The other thing I find frustrating is we talk a lot about vaginal dryness as a symptom of the peri and postmenopause, but it makes it sort of sound, oh, it's just a bit of dry skin, it's just a bit dry. And it really sort of underplays how significant this issue is. Can you explain to the audience a little bit more what it really means for people?
Yeah. So, I think we dismiss it until we realize, people go to the doctor for dry eyes. They go to the doctor for dry mouth. There's a lot of things that are dry that we go seek medical attention for and that we don't blow off. We're it's just a little bit of dry eye. And you're like, no, it's a massive problem when your eyelids don't slide over your eyeballs, right? It's completely disruptive to your day. And so nobody gets vaginal dryness until they have vaginal dryness or talk to women with vaginal dryness. And then you're like, this is very, very uncomfortable. It's a big problem, let alone more urinary tract infections, pain with intimacy, burning when you pee, getting up at night to urinate. So hormones and hormone receptors are in all cells, in all organs of the body. And I think part of the miseducation about midlife health is that menopause just means you can't get pregnant and you have hot flashes. And those are symptoms of what happens from low hormones, not actually what's happening to your body. And so in your pelvis, you have your bladder, your vagina, your vulva, your sexual structures, your clitoris, and they all change, or what we call atrophy or decline, in midlife. That can happen before your periods stop. It can happen in perimenopause. It can actually happen when you're breastfeeding because that's a low estrogen state. And certainly gets worse post-menopause to the point where I'll see a woman 7 years post-periods and she'll be like, how is this menopause? My last period was 7 years ago. And I'm like, you don't understand the consequences of low hormones keep happening and compounding. And so all of that constellation that I talked about, from the bladder to the infections to pain with sex to dryness, is called genital urinary syndrome of menopause, because it just helps explain more the constellation of pelvic issues because of low estrogen.
And so, Kelly, what is the best way of treating this genital urinary syndrome of menopause?
Putting the hormones back. So local hormone therapy. Vaginal estrogen is the most common. There are variants of that. And people just have to realize, because people will be like, what moisturizer, what, blah, blah, blah. I'm like, well, those are Band-Aids and they can make tissues feel better, but you're not actually regrowing healthy tissue. You're not actually giving the cells what they need to function optimally. So in many countries, vaginal estrogen is over the counter. It's not in America. It actually can be not in Australia. It can be pretty cheap. We've got some places, we have an amazing online pharmacy in America. You can get your prescription transferred. It's $13 for a tube. So I always joke, I'm like, not many things are actually getting cheaper right now in the world, but vaginal estrogen is. And it should be, because this medication's been around for over 50 years. The most expensive part of this medication is the tube that it comes in. And so anybody who is paying, $200, because I'll see it in our country, insurance companies will make money off of you. That it doesn't have to cost that much. Because once you stop, this is the other myth, I'll just use a tube of cream, I'll stop, right? It's like, no, this is like sunscreen, seat belts, flossing your teeth, is like the benefits only come while you're using it, and then will stop again when you stop using it.
I'd like to stay on the subject of this, Kelly. One of the things I find, as you said, people stop it. They also, like in the US, we pull out a leaflet and it's got all these scary potential side effects. I have to say, I do frequently get phone calls back to the clinic, because sometimes people are overwhelmed with the amount of information, and they'll phone and they'll say, oh, I've just opened the vaginal estrogen. I'm really scared by the leaflet. What is the message around how long we're going to need to continue using this? It's pretty much a forever kind of thing, isn't it?
Mm-hmm. As long as you want it to work, and it's funny because we, really with vaginal estrogen, so just for the listeners, it's really low dose. It's not considered systemic, and the fact that it doesn't increase your blood levels measurably, it's very low dose compared to even low dose hormone therapy. And so really understanding this is skincare, and skincare for down there. And you stop using your skincare, your skin stops getting the benefit of the skincare. We joke and we say you can take it to the grave. But as far as it being a preventative treatment, right? In our healthcare system, we're a sick care system. So we don't really work on preserving function. We only work on treating you once you're already broken. So there's really a strong argument to be made that maybe 55, kind of certainly if you're having symptoms, just starting on the skincare, because if 50 to 80% of women will experience genital urinary syndrome of menopause, why are we waiting for them to rack up the bills of treatment and urinary tract infections and risks of antibiotics instead of using a preventative therapy? And in people who start it because of UTIs or because of pain with sex, we have them keep using it as a preventative therapy. So it makes sense to really push the conversation on prevention better than treatment.
Kelly, what about this cohort of women who for the last 20 years, so if you think of the women who are maybe 70 now, who kind of missed out on having hormones because of the WHI, and obviously I've worked in Northern Ireland and in Australia over that period of time, and definitely hormones were so out. Like, we were pretty much told to get everybody off them 20 years ago, and prescribing was historically very low. And I believe there is this big cohort of women who unfortunately had the greatest disservice done to them. But, you know, they're those patients who come into me always with a little tub of urine. They've just endlessly got UTIs. They literally always have a little tub of urine in their handbag. I think I've got another UTI. I think I've got another UTI. And I know that within our audience, we definitely have health practitioners and lay people. But what do you think about, like, I will put those women onto vaginal estrogen, but I know that some doctors and health professionals are quite concerned to do that in an older person. Could you provide us with some thoughts or reassurance around that?
Yeah, with vaginal estrogen, I would say the consensus is now any age, any woman can use it. Is the only asterisk would be if you're actively being treated for breast cancer, get the blessing of the oncologist. But even then, we've got pretty good data saying even active breast cancer treatment can take it. Because again, remember, I'm going to start you on your vaginal estrogen. I'm going to check your blood levels. You know, I don't check blood levels, but I'm saying one could check blood levels, and you're not raising anybody above the postmenopausal level as far as estradiol goes, because this is a year's worth of vaginal estrogen is about equivalent to one oral estradiol, 1 milligram pill.
It's amazing. It's just so little.
Yeah, it's just crazy. It's literally skincare, and why anybody would withhold that to anybody makes no sense. And in America, we have an active petition to our Food and Drug Administration right now because doctors 2 times have formally requested the FDA to pull the boxed warning off of vaginal estrogen, and they've declined 2 times. So now we're taking it to the people, and we're saying, listen, the FDA works for the people, not the doctors, not pharma. We want the people, and there's a petition on letstalkmenopause.org for anybody who wants to do that. You do have to live in the U.S. to do it because it's our FDA. But we're basically saying the failure to take the incorrect messaging off of the label is actually actively harming people because it's withholding a very safe medication because of inaccurate messaging.
So what does it say on your label?
Probable dementia. Not possible. Probable dementia. Stroke, heart attack, liver disease, blood clots, which all stemmed from the WHI, with oral synthetic medications, so different product than local, bioidentical vaginal estrogen. And a lot of those had been walked back, right? So the label is wrong for everything, but the FDA put that label on. We don't care what dose, we don't care if it's synthetic or bioidentical, just anything that's estrogen gets this label, and now basically it's all wrong. But we're like, low-hanging fruit is the vaginal estrogen, take it off of that. We might let other people fight the other estrogens, but the vaginal one's such low-hanging fruit. We're like, get it off of this product. So,
Kelly, I know that you're always very open and honest around sex and, trying to give some sex education to adults. One of the things that I see a lot in my clinic, in fact, it's probably mentioned in almost every menopause transition consult, is women either complaining of low libido or painful sex and a clear feeling of guilt towards their partner. Often there's tears shed because they're really worried that their partner is going to leave them. they often kind of, I call it lie back and think of England. They put up with it or do it just to please him. Because they feel like that's kind of their wifely or partner duty. But I'd love you to talk to us a little bit. I mean, I certainly feel like everyone thinks everyone's having lots of sex, but the reality is, and I admit, obviously I'm seeing a skewed population, because obviously it's only the people who have a problem come and see me. But the reality is that in midlife, when it's mostly the time of peri and postmenopause for people are struggling with sex. I'd love you to talk to that. And I suppose in ways to reassure anyone listening that they're not alone in this situation.
Yeah. I mean, that's the reason I wrote the book, is because the sex education just doesn't, when we get sex education, it is, you're a teenager, maybe if you're not like a junior teenager, you're not in a long-term committed relationship. Your body's not going through midlife hormone changes. You don't have a full-time job with stresses and kids. Like, midlife sex is a different beast than trying not to get pregnant and trying not to get a disease when you're 17 years old, right? Like, some people still have to worry about that, but that's not all we have to worry about with midlife sex. And so it's really the adult sex education that we never got. And so we got crappy education, and now we have a problem. We never learned to talk about sex when it was going well, which would set us up for talking about it when it's not going well. Right? So communication was never taught. Consent was never taught. The fact that doing it for duty or guilt sex, that's not sexy. That doesn't help desire. And as far as pain goes, I have women come to me and they're like, I have two problems. I have low sexual desire and I have pain. And I always like taking problems away from people. So I'm like, no, you have one problem. You have pain with sex. You'll never desire hitting your finger with a hammer. Right? So it's like, you got to address the pain. You have to refocus the fact that this is supposed to be fun. This is adult play. We're not supposed to take it so seriously. And like, to get people back to like, what's the point of sex? The point of sex is not just to like put a penis in a vagina to keep a marriage intact, right? Like, there's so much more than that. And sometimes we have to go way back. And that's why I wrote the book, because I realized I can recommend lube. I can give the guy Viagra. I can give her vaginal estrogen. I can send you to a pelvic floor physio so the pain's better. Like, I can make you have a perfect pelvis. But if you think sex is a chore, if you've never had pleasure, you're doing it for somebody else's pleasure. If you got raised to think your body is dirty, if you can't touch yourself, right? There's all of that. It's really the biopsychosocial that ties into your adult sex life. And so it's like, I can't just be good at biology and have you have a good sex life. You've got to be good at communication. You've got to be good at understanding how women are socialized to not want too much. It's not about you, right? And then they're like, I don't want it. And I'm like, it's never been about you. Why would you want that? Right? And really just re-educating women to be like, this can be yours. And sometimes it's very hard to be like, what do you want? They're like, I don't even know what's on the menu, right? It's like, you can kind of work backwards and be like, what don't you want? And then kind of dive into a sex life from there. And it's interesting to look at the research on people who have great sex lives, right? So you're like, what's the secret to a great sex life according to the people who are like, I have a great sex life, right? Let's ask them. Not one in like the top 10 do they say, I have a great sex life because I spontaneously desire sex. It's not in the top, right? And so many people are like, I don't spontaneously desire sex, so I don't have a sex life. And I'm like, it's not an essential ingredient. And really kind of, one of my chapters of the book is F desire, right? Because so many people will stop because they're like, I don't really want it right now. And I'm like, of course you don't want it right now. Like, you're on a podcast with me across the ocean, like talking, right? Like, you have to put yourself in a pleasing sexual context that actually benefits you. And then you're like, this is real nice. I forgot. This is good, right? And like understanding how to transition into that sexual environment instead of like, we're not light switches. We don't just want it all the time. And that's incredibly unnormal thing.
And while we're talking about this, let's talk a little bit about using testosterone in women to help with desire.
Well, you guys are the leaders with availability. But what I hear about Australia is although you have a female dosed product, it's called Androfem, it's hard to get it. It's expensive, and it's still hard to find a doctor who will prescribe it. And you'll only prescribe, you all in Australia will only prescribe it, y'all, for low desire. And so women contact me and they're like, should I lie to my Australian physician and tell them I have low desire so I can get testosterone?
Well, it's like anything. You just got to find the right doctor. But I think that, so Androfem, we are really lucky. It costs about $90 to $100 Australian dollars. So that's, I think, about...
Is that for a month's worth or 3 months worth?
No, so that will last
How long
you...
does the
It
tube
will
last?
last you 3 months. So it's got 50 grams in the tube, and our starting dose is 0.5. So it's going to last you 100 days roughly. So it lasts quite a long time.
Oh, that's
and
good.
That's roughly, so I don't know, 140 or 150 US dollars. But look, it's fantastic that we have it. It does come with a really stupid syringe, I'm going to say.
But they're changing that.
Oh,
they're changing the packaging.
Oh, it's so frustrating.
I know a lot.
You're in the know. But yes.
I know things that are coming down the pipeline. It will get better.
So anyone listening who has just started testosterone or is thinking about starting testosterone, Kelly, what can they expect? Are they going to get a result or an improvement in a week, 2 weeks, 3 months? How long is it going to take?
I always back up and be like, I can't be the crazy doctor that tells women to go on testosterone if I don't educate them to be like, ovaries make testosterone.
Yeah.
Right. So you always have to step back because otherwise they're like, you're trying to turn me into a man. Then it's like, no, I'm just trying to give you what you had when you were 30. So ovaries make testosterone. Via testosterone, it converts into estrogen. So we have about, women make testosterone in 3 different ways. Ovary, about 50% of it, adrenal gland, another about 50% of it. But there's also end organ conversion where we're making it in muscles, in brain, in end organs. So specifically in the ovary, we decrease our ovarian production starting in our 20s. And it's more of a linear to the data that we have, right? And I would say I would love more studies on it. The data we have, you get about 50% of your ovarian testosterone in midlife compared to when you were in your 20s. So certainly there's nothing magical about your last period happening and being in postmenopause as far as testosterone goes. It's linearly declining from much earlier on. And I think that corresponds with the highest rate of distress with low desire is in the perimenopause age group. When you look at the studies looking at low desire plus bother by low desire. There's 80-year-olds who have low desire. They're less bothered by it, probably for a partnership reason, like if you don't have somebody to be sexual with, right? So the linear decrease in testosterone lines up with the perimenopausal highest rate of bother with low desire. Testosterone is a brain hormone, right? I think we did an error when we labeled these sex hormones because that makes it sound extra. That makes it sound just like it's for sex. But I always ask people, where does libido come from? It doesn't come from the clitoris, right? Like libido's a mood. Moods from the brain. Therefore, testosterone works in the brain by influencing moods. And then people are like, oh. And then it's also true that there isn't one spot in the brain for mood that only has the testosterone receptors. The testosterone receptors are everywhere. Louise Newsom's group just published an article this summer looking at mood and testosterone, and they had women already on estrogen, so they didn't adjust any other hormones at the time. And then they measured domains for mood and cognition at baseline, and then 4 months after starting testosterone, there was a 50% increase in mood and cognition. Now, I would love to see a placebo study, but the haters will say some of that's placebo, and I'm like, okay, but like lots of things are placebo, and they do well, right? And it correlates to how well men's moods get when their testosterone's replaced. So I don't think it's a huge fluke, but it's not just libido that gets better. Cognition and mood gets better. But to answer your question, it doesn't usually happen overnight. I do get some women who are like, aha, testosterone, that took a week. But a lot of women are like 4 months, 6 months kicking in. And when you dose it physiologically, which is what you do with the cream, or in America, commonly we'll either compound the cream or we'll dose a male product at 1/10 the dose to get a female dosing. when you get transdermal administration, it is slower of an onset, and I think that's good. I think the side effects come in. We do pellets. Do you have pellets in Australia?
Not really.
Not
a little
really.
bit, but not really.
Yeah, good for you. That's probably because you have legitimate products. Like we don't have legitimate products, right? So women are kind of forced to use pellets. But that's more of a 0 to 300 overnight phenomenon, and so it's kind of can be a shock to the body. And that's where you can see a lot of side effects. And plus, it pushes people to a very high level. You're going to start to see more androgenic side effects than if you use the appropriately dosed, which will get you up to a nice level. It's hard to get you too high, but it can take 4 to 6 months. I've got some people that are like, at 4 months, I was like, oh, there's my libido, right? Like, it'll just be like, you start to notice things. And I like that it's more subtle and like sustained than not.
That's my experience too with my patients. I definitely feel that with estradiol, you get a result, an improvement in various symptoms really quite quickly. I feel like testosterone's a bit more of a slow burn. And I usually say to patients, look, we're probably going to have to use 2 tubes of this before we make a decision as to whether it's helped or not.
Nice. I mean, I think part of that is like you got to up-regulate your receptors. Like everybody forgets to talk about the receptors. But it's like, we don't have a test for that, right? It's hard to measure. But it's like, remember, it's not always the dose of the testosterone, but it's like, how active are the receptors? You haven't had testosterone in your body for 10, 15 years. You kind of got to upregulate. Your body's like, oh, I can stop looking for this because it's not here, right? So you got to like upregulate the receptors again, get things to kind of get back into where it used to be.
Kelly, quite new to us in Australia is having vaginal DHEA, which we were all quite excited about getting.
Chef's kiss. I love it.
Can you explain why it's important to have something like DHEA and what the impacts of receptors? Because we've always thought of vaginal tissue as having estrogen receptors. But again, people listening might be surprised to know that actually there's also testosterone receptors around that pelvic area. Can you talk to that a little bit and why it might be beneficial to try the DHEA option?
So going back to the genital urinary syndrome of menopause, we kind of make it a short conversation by saying estrogen levels go down and you replace the estrogen levels. But that does, that's like calling estrogen the only menopause hormone. It's like, it's kind of true, but it's not even the main one, right? People don't know that we have 4 times the amount of testosterone in our bodies than estrogen when we're fully functionally hormonally. And so it's no different down the pelvis, right? And testosterone in the pelvis, testosterone itself helps with all domains of sexuality. So not just desire, but also arousal, orgasm. Some people will say my desire's not so much better, but like my orgasms are more intense or my orgasms happen easier, or it's just easier to get aroused. So testosterone helps in all of those things. And what DHEA is a precursor hormone that within the vagina converts to testosterone and estrogen. So you're really giving one thing that converts to both things. And especially in America, vaginal estrogen is pennies on the dollar of what DHEA is. And so I say, if I was given vaginal DHEA and vaginal estrogen and said pick one and the price was the same, I would pick the vaginal DHEA. It's a beautiful suppository. It reaches the vulva. It makes beautiful, healthy, moist, hormonally replete vulvas, but it's very expensive. And so I tend to save it for either my really atrophic ladies or somebody who's kind of just failed vaginal estrogen. And then I'm like, or somebody who like, I really need them to see a win, right? Like they've been struggling a lot. Vaginal estrogen isn't working, or maybe vaginal estrogen's too burny. Some people don't like what's in the cream. And I'm like, just pay with your own money for 2 months of this stuff. I need you to see what a healthy vulva is like. And then they'll do that and they'll be like, oh my God.
One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard, and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment, which is why I've created the Menopause Appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs, and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight, and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis, and leave you with a comprehensive, tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrShaunaWatts.com.au. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.